We will move ahead with Dr. Mahesh Shanmugam's presentation. Thank you so much, sir. We can see your screen.
Yeah, thank you. So I'll be showing a 37-year-old type 2 diabetic. She's one-eyed and she had a preoperative vision of count fingers at half meter. And preoperative, she had a total TRD or a CRD. It was not very clear because there was a cataract and synechia fundus view. And these were the intraoperative anticipated issues. Once I show the video, you'll see, because like after small people, I don't have a preoperative photograph. There's no PVD extending from the disc to the periphery. So entry into subhyaloid space was difficult to dissect. And unless we go into the subhyaloid space, it's going to be difficult to dissect. There are umpteen number of vascular nails anchoring the fibrovascular proliferation to the retina. And so there's a risk of breaks and bleeds. And in addition, the patient had a very, very thin atrophic retina. It was diaphanous retina. And once we have a break with the fibrous tissue not dissected, it's going to be a case probably heading for abandoning the surgery. So that's how it was. And let's look at the surgery now. So we had given up anti-VEGF 3 days earlier and autologous plasmin on the day of the surgery, and went to get to the surgery. So you can see the fibrous tissue and not a single vessel appears patent, and you can see subretinal gliotic bands as well, indicating that this TRD or CRD has been there for a long time. Tried looking for an area of small hyaloid separation somewhere in the inferior temporal quadrant. So found one area where there was a little bit of separation. And you can see the SRG so clearly because the retina is so diaphanous. You can see all the vessels are sclerosed. And pulling on the hyaloid like this to make an opening was not possible to create a detachment. So had to do an extensive bimanual dissection. The initial progress was extremely slow because of multiple vascular nails. And a break at this point in time is a recipe for disaster because the retina will become bullous and it's going to be extremely difficult to dissect this extensive fibrous tissue of the retina. So very carefully, the hyaloid, which is absolutely plastered to the retina, was being dissected very gently. And I'm using the cutter to create a plane between the vascularized hyaloid and the retina. And cutter is not activated. It's just being inserted inside like a spatula to create that cleavage plane. And you can see the scissors sometimes goes with the curved blades towards the retina, sometimes facing up like this, and depending on how the situation is. And we are at a point that we managed to create some amount of separation of the hyaloid. The painstaking dissection which had to be done because one single break would mean that like the surgery is going to become much more difficult than what it already is. So finally, the inferior part of the fibrous tissue could be removed, and we still have about the superior part of the fibrous tissue. So here, starting the dissection posterior and extending anteriorly, and then creating islands of tissue that's somewhere where the macula should be. And once again, using the cutter to create a tissue plane. And that's the last bit of the fibrous tissue in the superior part, which is being removed. So now the retina is mobile. And despite the preoperative anti-VEGF, there was some amount of bleeding. So now used perfluorocarbon to see where the break is, if there was a break at all. But despite putting a small bubble of perfluorocarbon and rolling the eye, I couldn't find a break. So I probably thought it was just a extensive TRD, a TRD which was involving almost all the whole of the retina. But then there was significant amount of subretinal fluid, and I didn't want to do a drainage retinotomy, so did a transscleral drainage. So that was a 26 gauge needle loaded onto a 2cc syringe with a plunger removed. You can see that is the depression area of the sclera and the choroid. So very gently, you can see the needle entering the subretinal space tangentially with the bevel facing the RPE. So this way, I avoided the retinotomy in this patient because the retina is still not completely mobile or free because of the long-standing TRD, though I had removed all the fibrous tissue. There's a post-operative appearance after PFCL removal because I left the PFCL in place for about 2 weeks. But it was not all hunky-dory. Despite the good anatomical result, there was some elevated intraocular pressure with the PFCL in situ as well as even after removal. And 1 week after with PFCL in situ, she had about hand movements, 2 meters vision. But post PFCL removal, vision actually dropped. So I was wondering if it could have been managed any differently and if there are any reasons for the poor visual outcome. Thank you.
Excellent case. Absolutely phenomenal surgery, as always. But I think, sir, I cannot think of anything else. Anybody has anything, any other thoughts managing this case?
Yeah, I have.
Yeah,
Because
Fantastic.
Mahesh sir showed this case, don't operate this case. He can operate it. After 3 hours, it will fail for me, and I should know my limitations.
Anand Rajendran, any thoughts?
Yeah, excellent surgery. I mean, like Gopal said, for many people, this must have been an inoperable case. People write it off. Just a question. Once you start with that massive amount of FEP, what are your thoughts of using visco dissection? I don't use it a lot personally, but I know people who do, but not at the absolute onset of the case. But once you make significant inroads into that large fibrovascular, sheet or blanket, as I would call it, to help you go further, once you make certain amount of dissections, radial dissections inside, do you, consider putting in visco dissection? Because primarily your case at the beginning looked perhaps like a tractional detachment, or if it is just traction without a regma. Would you think that it will make your task easier? Or have you had experiences where you've benefited from using visco dissection in such situations?
Yeah, I have used viscoelastic dissection. I do make a small opening and inject viscoelastic, but this case was different in the sense that it now so diaphanous. So I was wondering if the viscoelastic will tear and go into the subretinal space. So that is the reason I didn't use viscoelastic in this particular case.
Yeah.
Dr. Parveen, you had some comment?
Yeah, I think, of course, no need to say that wonderfully done surgery. Only a few things which come to my mind, because we also see very bad such cases in Chankanetale. So one is, sir, I wonder whether Avastin was 3 days ahead only, whether we could have increased it to 4 or 5 days, because I don't think it is a burnt out diabetic retinopathy, because they burst significantly. And when you give Avastin a little earlier, the separation between the gel vitreous and the retina, especially when it is very thin, becomes a little easier. Number one thing which comes to my mind. Second thing is that I'm usually very, very aggressive with bleeding whenever it happens. Immediately, if you cauterize the bleeder so that the pool of heme does not accumulate at all, because the thin retina will not allow you to separate the blood clot from retina at all at that point of time. And I minimize the use of cutter when I use this surgery, because the more segmentation you do, the more chance of bleeding. What do you think about it, sir?
I agree, Dr. Parveen. I agree. The only thing is, like, this preoperative, it looked pretty much like almost avascular except for the large blood vessels within the fibrous tissue. Some of these cases, despite the fact they look avascular, they do bleed. That's the reason I gave anti-VEGF. And I usually operate about 3 to 5 days after anti-VEGF. And this patient was from out of station and she couldn't stay for too long as well. That is another reason why we operated 3 days earlier. Sorry, within 3 days of anti-VEGF. So, and cautery, yes, cautery is actually a double-edged sword. So if you have a graded cautery where you are able to titrate the amount of cautery, then it's okay. But otherwise, like sometimes it can create a break where you don't want it to. So that is the issue. So I usually go ahead, dissect the whole thing and then cauterize. And then I don't stop to cauterize, because if I stop to cauterize, sometimes, as I mentioned, I may create a break, or sometimes like it like interferes with the flow of my surgery. So that's the reason I usually cauterize at the end of the surgery.
So sometimes increasing intraocular pressure can help at that point of time. Though, of course, disc is pale, so perfusion is reduced. But if you suddenly increase pressure so that it doesn't bleed also, and you don't have to come out to exchange instrument also. Wonderfully done surgery. And anatomy, I think functional results don't say much about these cases that we work so hard on. But then that's how VR surgery is all about.
Thank you.
Hemant sir, any quick comment?
Yeah, I just wanted to ask Mahesh, you very well done surgery.
what was the reason of using PFCL? Because you said that there are no breaks. So, I mean, what was the reason why PFCL was used initially and then exchanged to silicon oil, and why not silicon oil in the first instance?
Why I used PFCL because the retina was still stiff, though, because it's been a very, very long-standing PRD, so it was not going back to its place. So, and inferior retina, as you can see, that subretinal bands are there extensively. And though I could not see a break, I was not sure that I was not missing a break, because I didn't want to use a backflash and try to create a break if there's not one. So I wanted the inferior retina to attach. That's the reason I thought I'd leave the PFCL in place to stretch the retina to some extent. I used this in post-traumatic patients also. And subsequently, a week or two later, exchange for silicon oil. But like, fortunately, we didn't have to, because it's completely attached, that we could remove the PFCL about 2 to 3 weeks later, and we didn't replace it with silicon oil.
Just a quick comment. Just a quick comment, about what Dr. Parveen was saying, and those queries about, reason for vision loss. Sometimes when we extend the duration between Avastin and surgery, you can actually increase the crunch and also the sclerosis. So sometimes I think a middle road of thing was almost everybody has kind of hit upon, this 3-day period. So I think that helps. Sometimes in these very bad ischemic cases, you increase that duration, allow Avastin to be in the eye for too long. It might actually, kind of worsen the ischemia. That's a possibility.
So 3 to 5 days. 3 to 5 days is, I think, is
yeah.
the ideal.
So I think that's
all right. I